He's professor of surgery at University of Iowa. He's also the director of the North American Neuroendocrine Tumor Society, NANETS. He's the director of surgical oncology and director of endocrine surgery at University of Iowa in Iowa City, and is one of the great neuroendocrine surgeons in the country. We're really honored to have him here today to be our first speaker of the afternoon. He's also a specialist in genetics and genomic changes in neuroendocrine tumors. So, with no further ado, I'd like to introduce Dr. Howe.
Thank you, Ed.
Thank you.
That's a very kind introduction, and so thanks a lot for having me here today. We're going to talk about surgery for your pancreatic neuroendocrine tumor, and we're going to talk a little bit about what the pancreas does, what it is, where it's located, and then we'll talk about some operations. If you're squeamish, there's going to be some pictures, so just be forewarned. Okay, so what is the pancreas? Pancreas is basically an organ in the digestive system. It's located right here. It's kind of in the back of the abdomen. It's behind the stomach, adjacent to the duodenum and the spleen. This is the normal anatomy of the pancreas, and we can see that the pancreas is kind of nestled in this, what we call the C-loop of the duodenum, and they share common blood supply. There's a duodenum on the other side. In the tail, you see the spleen. And then the bile duct runs through the back of the pancreas and meets up with the pancreatic duct. There's also some important vascular structures, such as the celiac axis, which brings the blood supply to the liver and to the spleen and to the stomach. And underneath the pancreas runs the superior mesenteric vein, which takes all the blood from the intestines up to the liver. And there's a superior mesenteric artery, which brings the arterial blood flow into the small intestine. There are several different parts of the pancreas. There's the head, and that's the part right here, closest to the duodenum. There's the uncinate process, which is that portion which is behind the superior mesenteric vein. There's the neck, which is that part right over the superior mesenteric vein. There's the body, which is the part to the left of the superior mesenteric vein. And finally, the tail, which is the part kind of out at the end near the spleen. The pancreas has two main functions. One is called exocrine, and that's its digestive function, and the other one's endocrine. Now, the exocrine function has to do with making of enzymes, and that comes from a particular type of cell called the acinar cells. And the majority of the pancreas is made up of these acinar cells, which make enzymes that help you break down food. It makes amylase, which breaks down sugar, lipase, which breaks down fat, and peptidases, which break down proteins. And it also makes high levels of bicarbonate to neutralize stomach acid. And those enzymes are secreted into the pancreatic duct, which kind of runs through here, and right about here it joins up with the common bile duct. This is important later when you talk about operations because of this anatomy. And then they empty into the duodenum. That's where the bicarbonate neutralizes stomach acid. That's where the enzymes meet up with the food and help with digestion. But the neuroendocrine tumors come from the endocrine cells, and these are also known as pancreatic islet cells, and they're just like small little islands of neuroendocrine tissue that are distributed throughout the pancreas, and they make different hormones like insulin and glucagon and some other ones we'll talk about later. And this is just what a pancreatic islet looks like. In the center, there's this little island of neuroendocrine tissue amongst all these other things, which are more acinar cells. Now, a pancreatic neuroendocrine tumor is when one of these islets grows into a bigger lesion, shown here, and there are different operations depending on where the tumor is located. So this is what one of these pancreatic tumors look like in the operating room. Here's the normal pancreas. You can see this more pale yellow here, and then there's the tumor right there. This shows a different pancreatic tumor. I don't know if you can see this very well with the room lighting, But here's a normal pancreas that's been mobilized up out of the abdomen, and here's the tumor right here. This is in the tail of the gland. You can see that the pancreas itself is kind of a pale yellow, and this tumor is a little more reddish in color, and is multilobulated, and it looks kind of ugly. So who gets pancreatic neuroendocrine tumors? You kind of know a few of these people probably, and 2 of them are alive and 1 is not alive anymore. And Dr. Henderson did a nice study where he tried to look at risk factors for pancreatic neuroendocrine tumors, and they're really not the same as what you get with adenocarcinoma of the pancreas, which is associated with smoking and drinking. Family history of cancer and diabetes are risk factors. Other risk factors are if you have a familial condition like multiple endocrine neoplasia type 1. There, people will get tumors of the pituitary gland, of the parathyroid glands, and of the pancreas. There's another familial condition that's called von Hippel-Lindau, where people get an even more dizzying array of different lesions. They get hemangioblastomas of the cerebellum, of the retina. They get renal cell carcinomas. They get pheochromocytomas, which is an adrenaline-producing tumor of the adrenal gland. And they get pancreatic neuroendocrine tumors, as well as pancreatic cysts. Now, in these familial conditions, the risk of actually developing a pancreatic neuroendocrine tumor with MEN1 is as high as 30 to 80%. With von Hippel-Lindau, it's 10 to 17%. And there's another condition called neurofibromatosis where the risk is about 10%, and 2 other conditions called tuberous sclerosis 1 and 2 where the risk is only about 1%. But these are the familial conditions that will predispose to developing a pancreatic neuroendocrine tumor. And patients with a familial condition are usually born with a mutation in all their cells that lead to the predisposition to get these tumors. And often when they get these tumors, it's not going to be just one of them. It might be multiple tumors throughout the gland. And that makes their management a little more complicated. Now, this just shows the increasing incidence of pancreatic neuroendocrine tumors over the last 4 decades, from 1973 to 2012. And they've gone from about 2 cases per million to about 8 cases per million for a 4-fold increase. Small bowel neuroendocrine tumors have increased about 6-fold in the same time period. And it's not really clear why this is happening, but the most likely explanation is not that we have an epidemic of these tumors, but a lot of people are getting CAT scans for a variety of reasons, and we're picking these tumors up before people probably weren't diagnosed. Now, there may be other environmental influences. A lot has changed over the last 4 decades, but probably one of the biggest explanations is the increased use of imaging and the increased quality of imaging. So how do we make the diagnosis of a PNET? Well, patients may have symptoms. Some of these tumors secrete large amounts of hormones like insulin or glucagon or gastrin, and that will lead to a clinical syndrome. But other patients who don't make high levels of these functional hormones may just have vague abdominal pain or some other abdominal complaint that's going to result in them getting a CAT scan. And on the CAT scan, you may see this neuroendocrine tumor, or you may see a spot in the liver that turns out to have come from a neuroendocrine tumor in the pancreas. Once you see one of these tumors, we usually send off a battery of blood tests looking for the different hormones that the pancreas might make in excess. And eventually, though, to make the diagnosis, you're going to need a biopsy. The most common way to do this is endoscopically. So they put a scope down into your stomach, and there's a special scope that has an ultrasound probe on the end of it, and you can see the pancreas through the stomach, and you can put a needle through the stomach into the pancreas and get a good quality biopsy. Biopsies can also be done by CT scan as well. Now, this is a typical patient that we see with a PNET who's had some vague abdominal pain, and they got a CAT scan. The one on the left is what we call a transverse image, and that's basically taking cuts from the back to the front. And the one on the right is a coronal image, which is kind of up to down. What we see here is the liver. The pancreas is here. This is normal pancreas, but at the end of the pancreas, there's this darker area with a central white spot, which is a calcification. This is the spleen. So what that is, that darker spot is a pancreatic neuroendocrine tumor. And you can see it on both the axial and the coronal cuts. Now, what we also see are a bunch of spots in the liver, and this represents liver metastases. All these things, this is one of those bullseye kind of lesions that was referred to earlier. Now, the same patient with a DOTA PET scan, we can confirm that this is a neuroendocrine tumor by its uptake of somatostatin. So again, that same tumor, you see uptake in the tail, and you also see uptake in the liver metastases. So let's just talk about some general facts about PNETs. First of all, the average age of patients getting pancreatic neuroendocrine tumors is about 58 years. The sex distribution is about 55% male and 45% female. And this is a study done by Dr. Henderson, looking at 1,483 patients from a national database. With respect to the ethnicity, it's pretty similar to the American population. And with respect to how patients present, a low number of patients are going to present with localized disease. That means it's isolated to the pancreas. And then about 21% are going to have spread to the regional lymph nodes, and about 60% are going to have spread to the liver or distant sites. The incidence of functionality is about, in this study, was 90% were non-functional. And again, in these national databases, that could be an overestimate because not everybody had blood testing for the different hormones that could be made. With respect to survivorship in patients with PNETs from this very large population-based study, the median 5-year survival of patients overall was, boy, I can barely read this. I guess you guys probably can't either. Was about 32 months, or no, sorry, 32% of people were alive in 5 years, and the median survival was 28 months. Now, if you had a functional tumor, it was a little bit better. The survival was 47% at 5 years, but if it was non-functional, it was down to about 30%. Now, if you had disease that was localized to the pancreas, then you did better. You had a 61% 5-year survival. If it went to lymph nodes, it went down to 50%. And if it went to the liver, you were down to about 20% of people alive in 5 years. Now, this is a national database with all comers, which is different from single institutional studies. And this just shows the functional on the top curve versus the non-functional, with a 5-year survivor of 47% versus 31%. Now, as we mentioned, some of these tumors make hormones and some don't. When it doesn't make a hormone, it's called non-functional. When it makes a hormone, then it's functional. And those hormones might include insulin, gastrin, VIP, vasoactive intestinal peptide, glucagon, somatostatin, and we measure pancreatic polypeptide, but this isn't a hormone that causes a functional syndrome, but it's often elevated in patients with non-functional tumors. So let's just talk a little bit about the functional tumors. Let's talk about insulinoma first. Insulinoma is a pretty interesting tumor. Patients develop symptoms from the low blood sugar that they get because these tumors make high levels of insulin, and one of the manifestations is neurologic. People will often have double or blurred vision. They'll be confused. They may have abnormal behavior, and they can lose consciousness or go into a coma. They may even have seizures. The other symptoms that people get are from a release of adrenaline when you have these low blood sugars. And that causes sweating and anxiety, weakness or tremor, hunger and nausea, and palpitations. And what happens is after a while, people start to subjectively realize or subconsciously realize that they're developing these symptoms, and they understand that if they eat every 2 or 3 hours, that they can stave off these symptoms. And so a lot of times people have gained a bunch of weight because they're getting up every 2 or 3 hours to eat something, so these things don't happen to them. The diagnosis, a guy named Whipple in 1935 had something called his triad, the 3 different things you want to see, and that's hypoglycemia, a glucose less than 50, and relief of symptoms as soon as you take glucose. It's really remarkable. If somebody has a low blood sugar like this and you give them either an ampule of D50 or have them just drink some orange juice, within moments they'll come around again. In the hospital, to make the diagnosis, we used to do something called a 72-hour fast, where you wouldn't let people eat for a while. And you would wait till they developed these symptoms, and you would check levels of insulin and sugar and another fragment of insulin. And that's how you really kind of nail down the diagnosis. And the reason that's important is a lot of times these tumors are very, very small and they're hard to find. I mean, even a really tiny tumor can cause these horrible symptoms. So a pancreatic protocol CT is often enough to find it, but this is not going to show lesions less than 5 millimeters, and sometimes less than 10 millimeters are hard to see. So sometimes people get angiograms where you see a blush in the pancreas that will suggest an insulinoma. Other times you can do selective arterial sampling, which is a complicated interventional radiology procedure where you inject calcium into different arteries supplying different parts of the pancreas and then measuring insulin levels from the hepatic vein. It's not really done very much, but sometimes that'll help you figure out if it's in the head or the tail. Arteria scans aren't very valuable, and with DOTA PET, I just don't think there's enough information. And intraoperatively, you can do an ultrasound, which is a pretty decent way to find these lesions. Now, these tumors tend to be small, and because people have symptoms at such an early stage, most of these are going to be benign. Only about 10% are malignant. So this just shows where this patient's insulinoma is. You can see it's a relatively small tumor supplied by a few blood vessels, and you can do an operation called enucleation. And what enucleation means is just shell it out. You don't have to take the whole head of the pancreas and that's a Whipple procedure, for example. You can just shell these out and oversew the edges. The biggest risk of doing that, though, is that, remember we talked about the pancreatic duct and the fact that it makes all this juice. It's about 1 to 2 liters a day. If you have an opening of a pancreatic accessory duct coming out through here, it can leak pancreatic juice into your abdomen, and that can take a long time to heal. So, you know, any operation on the pancreas is not without its risk. In fact, there's a saying in surgery is that don't F with the pancreas, and it's because it's a very unforgiving organ. And I'm not going to say what the F stands for. This is just a picture of me enucleating this whitish tumor near this yellowish pancreas. We've rolled over the superior mesenteric vein. This is the uncinate process, and the tumor is right there. And you can, I don't know if you can appreciate it in this large room, but the tumor is kind of white and hard, and the pancreas is a little bit yellow and soft, and you can come right at the edge of this and just shell it out. Now, gastrinomas are interesting in their own right. There's a guy named Zollinger and his partner Ellison, who Dr. Odorisio worked very closely with for a long time at OSU. And they described 2 patients who had jejunal ulcers and they also had pancreatic tumors. And over the years, it was learned that patients with this Zollinger-Ellison syndrome had ulcers in odd locations. Most people get ulcers, it's in the duodenum, but these people get ulcers, lots of ulcers in the duodenum or in the jejunum, in places where you wouldn't normally get ulcers. And that's because there's so much stomach acid being produced by these tumors that make gastrin, which causes gastric acid to be made in the stomach. And these patients often have tumors either in the pancreas or even more commonly in the duodenum. It's about 3 cases per million per year, which might be an overestimate. About 3/4 of these are sporadic, and what that means is there's no family history. They just developed it out of the blue, as opposed to 25% who had a family history of MEN1. 60% of these gastrinomas are malignant, and often patients will have symptoms for about 5 to 7 years, and those will include belly pain, heartburn, diarrhea, or even worse, bleeding from these ulcers, perforation of the duodenum, or gastric outlet obstruction, which is when you have a bad enough scarring from the ulcers healing that the stomach can't get out, food can't get out of your stomach very well. The locations of gastrinomas can be in the gastrinoma triangle, which is this area that incorporates the duodenum and the pancreas here. And about 50% will be in the duodenum, and they can be very small and very difficult to locate. Well, about 1/4 of them will be in the pancreas, and then others will be originating apparently in lymph nodes or even other sites. They can be very difficult to find, and there's a lot of things you need to do to try to find them. The way you make the diagnosis is you have to prove that the patient makes a lot of stomach acid. They usually have a very high gastrin level, but if patients are on proton pump inhibitors, that will also raise the gastrin and make it difficult to interpret. And we used to give people an injection of secretin, which would then cause the gastrin to become even more elevated. So the management of them, well, if you're not sure where it is and they're having these bad ulcers, you can just treat them medically. You can give them antihistamine blockers like famotidine or proton pump inhibitors like omeprazole, but that doesn't really take care of the tumor. You can take out the whole stomach and that'll get rid of all the acid production, but they still probably have a tumor in their duodenum or their pancreas, so that doesn't cure them of the problem, but it cures them of the ulcer problem. Some patients with MEN1 have high calcium levels due to hyperparathyroidism, and that causes even more stomach acid secretion. So in those patients, you need to fix their parathyroids first, and then eventually, if possible, you want to remove the tumor. And that could either be an enucleation or a local excision from the duodenum or pancreas, or if it's in the tail of the gland, a distal pancreatectomy, or in the head of the gland, you do a Whipple procedure. Now, another interesting syndrome, they're all interesting because they cause, big-time problems. And the other one is VIPoma, and that's known as Verner Morrison syndrome. And Verner described this in 1958. And basically, patients get a very watery, profuse diarrhea, low potassium, and low stomach acid. And they can have diarrhea 3 liters a day, and they can get severely dehydrated from this. 85% of these tumors are in the pancreas, 15% are in the duodenum, and 40% at least are malignant. The diagnosis is made by the secretory diarrhea, the finding of elevated vasoactive intestinal peptide levels in the blood, and the pancreatic islet cell tumor. And the treatment initially is to give sandostatin to try to control the diarrhea, IV hydration, and then eventually to resect the lesions. Another tumor is a glucagonoma, and this can cause diabetes mellitus. Now, glucagon is a hormone that raises blood sugars, and so patients can present with diabetes, a necrolytic migratory rash that looks kind of like this. They get low amino acid levels, and they get deep venous thromboses. Somatostatinoma is another tumor, and again, these are all pretty rare. Here people again get diabetes, they can get gallstones, they get steatorrhea, and 50% of these tumors are in the pancreas, and again 50% are in the duodenum. 80% of these are malignant. So that's pretty much all of the functional lesions. So the question really is now, if you have a pancreatic neuroendocrine tumor, when should it be taken out? Should we take out all of these things, or should we just take out them selectively? And there's this is an ongoing area of debate. There are a lot of nuances to this, but one thing that people agree on is if the tumor is making large amounts of one of these hormones we just discussed, it should come out. All those syndromes are pretty bad, and even if you have a 1 centimeter tumor that's making insulin, you're going to be passing out and having all sorts of problems from it, so it needs to be removed. On the other hand, if it's not making a hormone, then the question is at what size should they come out? Should you take out everything that's seen on a CAT scan that somebody got for kidney stone, or do you only take out them over a certain size? Well, if a non-functional tumor is over 2 centimeters in size, there's about a 20% chance it's going to spread to lymph nodes, and about a 10% chance it's going to spread to the liver at about 2 centimeters. So that's kind of a cutoff that people use. If your tumor is over 2 centimeters, it should probably come out because of that risk of metastasis. On the other hand, if it's less than 1 centimeter and it was just picked up on a CAT scan done for something else, then the risk of metastasis is pretty low. Maybe it shouldn't come out. And as I sort of hinted at, we're not supposed to F with the pancreas. I mean, we do, but you don't want to mess with it for tumors that might stay 1 centimeter for the next 10 years, right? I mean, because the complications of pancreatic surgery are not small. So most people would agree that if the tumor is less than 1 centimeter and not making a hormone, that you don't need to take it out. It can be surveyed, and if it's growing on subsequent CAT scans, maybe you should take it out then. The controversy really comes in those tumors that are 1 to 2 centimeters in size. You know, if you have a patient who shows up to the clinic in a wheelchair, who's just had a heart attack, if the tumor is 1.5 centimeters, you're probably going to pass and just watch it. On the other hand, if it's a 35-year-old vigorous young man or woman who's in good shape, then who's going to live like 50 or 60 more years, then you might want to take it out, because eventually this tumor will probably grow. And so that's a very individual decision when the tumor is kind of in that range about whether you take it out or not. It's kind of a risk-benefit situation. Most people agree if you have multiple endocrine neoplasia, if the tumor is greater than 2 centimeters, you should take it out. Again, the problem with multiple endocrine neoplasia type 1 is that it's not just that one tumor. They're going to have 5 or 10 tumors in the pancreas. Maybe one's over 2 centimeters, but you might have 5 more that are 8 millimeters. And what do you do about them? It's a very individualized decision of what you do and what particular operation you do, and you may not be able to remove all the tumors. With von Hippel-Lindau, the teaching is to wait till it's about 3 centimeters. And in VHL, it's even more complicated, because a lot of these patients have these big cysts of the pancreas as well as the neuroendocrine tumors. There's some other situations that are worth discussing. One is, what do you do if a patient has a pancreatic neuroendocrine tumor and they have a lot of liver metastases? Do you go after the primary tumor in that situation? We could talk about that for about an hour, but it really depends on how much liver disease there is. If there's a little bit of liver disease, well, that's not really a contraindication, because we can remove the liver disease at the same time or do something about it. But if somebody presents with 50% of their liver full of tumor and there's not a real good operation that we can do for that, then the question is, would you just treat them with medical therapy and just watch the tumor, because their lifespan may not be dictated by the primary tumor, but rather the liver disease. It also depends on what the tumor is like. If the tumor is unresectable, that is, if it's invading into the superior mesenteric vein and would be very challenging to resect, and there's a lot of liver metastases, well, you may decide to treat that patient medically. Whereas if it's smaller and there's a manageable number of liver metastases, we would probably go after that. So again, you really need to do this on a case-by-case basis, to figure out if they're a good surgical candidate for removal of that tumor, or whether you should give them, say, capecitabine, temozolomide, PRRT, Afinitor, or Sutent. Now, the other situation where you want to really be careful about is if a patient has a high-grade tumor. Dr. Tang talked about the high-grade tumors. That's usually defined by a Ki-67 level of over 20%. And if it's poorly differentiated, that's another factor that would make it a neuroendocrine carcinoma versus a grade 3 neuroendocrine tumor. And the problem with patients who have these poorly differentiated tumors is it doesn't really matter what you do, they're not going to live a long time. So the surgery that we do for the pancreas can be fairly morbid. They can have high complication rates. And if somebody has a limited lifespan, you might not want to be taking time away for somebody to recover for a few months after pancreas surgery if their lifespan may be relatively short. These tumors, as mentioned, are generally pretty responsive to chemotherapy, but unfortunately those responses often don't last very long, and the tumors will come back. But there are certain situations where you would consider resection. So if the tumor is high grade, not if it's poorly differentiated, but if it's well differentiated and there are no metastases, you might consider resecting that primary tumor. And if the Ki-67 is in that lower range of, say, 20 to 30%, those are patients that still would be controversial to resect that, but you could argue that they may have a longer survival with resection than with treated medically alone. So let's talk about the different options. We already talked about enucleation and what's involved with that. There's also an operation called distal pancreatectomy, where you take out the end of the body and tail of the pancreas. There's this Whipple procedure, which we'll talk about. And then there's some laparoscopic procedures that we can do for this as well. So we talked about enucleation. This is just another picture of enucleation. This just shows that there's a P-shaped insulinoma, for example, in the soft pancreas. And you just come around the edge of the hard tumor and ligate the blood vessels as you go around, and that's all you need to do. You don't need to take out half the pancreas. You can just take out the tumor. Now the problem is, again, this is the pancreatic duct. If there's a branch that comes out right in the bed of what you took out, then that can cause issues with a leak from the pancreas. And those things, generally managed with having a drain in place for a long time, and don't need a reoperation, but sometimes that drain can be in for a long time and people can get infected collections of pancreatic juice. This just shows another picture of me doing an enucleation on somebody. Here's the tumor here. Here's the normal pancreas. And this one is kind of hanging off the top of the pancreas, so we can just divide the tissue underneath the tumor here. This is a picture of the tumor kind of rolled over. Here's the normal pancreas in here. This is kind of the cauterized edge of the pancreas. And what we've also done is we've done a regional lymph node dissection. So up here are the hepatic and splenic arteries, and we've cleared the lymph nodes along the hepatic and splenic artery and also along the superior mesenteric and splenic vein here. So we're enucleating the tumor, but also taking some of the regional lymph nodes in this operation. This is what a PNET looks like under the microscope. This is a tumor here with a capsule around it, and here's normal pancreas. And on a closer high-power view, you can see this is what a normal islet cell looks like, this little island of neuroendocrine cells. Here's the capsule of the gland, and here is what the tumor looks like. Now, if the tumor is in the body or tail of the pancreas, we do an operation that's called a distal pancreatectomy, and usually with a splenectomy, depending on how big the lesion is. This just shows a patient with a tumor in the tail of the gland, and you can see this is normal pancreas from here to here, but then it gets darker here, and there's a little spot of darkness there, and that represents this tumor. Now the spleen is over here, but the vein to the spleen runs through the back of the pancreas, and usually in these patients the vein is clotted off, and patients have developed collateral circulation to the stomach for the blood to get back out of the spleen, and they can be dangerous because of these enlarged veins. But usually because of that, the spleen will need to go when you take out the tumor. This just shows that picture I showed you at the beginning, again with the normal pancreas and the stomach up here. Here's the tumor right down here. And this is kind of in the body of the gland. So what we're going to do is we're going to mobilize the inferior border of the pancreas. We're going to mobilize the spleen, which is attached to the abdominal wall inside of the abdomen. And after careful dissection, we've kind of raised the spleen out of the abdomen. Here's the normal tail of the pancreas. Here's a big tumor. The inferior border is all dissected out. And here we have the splenic artery looped with a vessel loop to get ready to divide that. And this just shows a cartoon of that. Again, we're going to divide the pancreas. We'll often use a stapler. And we're going to staple the vein going to the spleen and oversew the artery here. And then this is going to be our specimen. And that's a distal pancreatectomy. The tumor is here. And this is kind of what it looks like after you remove the tumor. Here's normal pancreas. This is a staple line along the edge of the pancreas. Here's the edge of the splenic vein, and here's the edge of the splenic artery. And the specimen looks like this. That's that same tumor. And there's the tumor itself. There's the spleen. And there's the pancreatic margin of over a centimeter between the tumor and the edge of the pancreas. So that's kind of what we do for tumors out at the tail. Now, when the tumor is in the head of the pancreas, it gets a little more complicated because remember I mentioned that's where the bile duct runs through? So I'll discuss the complexity in just a second. This is a patient that I've taken care of, and again, this is the axial CT on the left. Here is the tumor. Here is an enlarged lymph node, and there's a duodenum being pushed out of the way. So this is a very large tumor, and if we look at the coronal cuts, again, we can see the duodenum being pushed out. We can see the tumor here, a very large lymph node. And what's interesting about this patient is they have tumor growing into the superior mesenteric vein. So this is a difficult situation where tumor is growing up into the vein, going up towards the liver, and if we're going to remove this tumor, we're also going to have to remove a portion of that vein and do a vein reconstruction. This just shows the pictures of doing a Whipple procedure, which is the operation that we're talking about. And one of the first maneuvers is to basically make a tunnel under the pancreas over the superior mesenteric vein. Now, in that last patient, that would be impossible because a tumor is growing right into that vein. So you'd have to resect the vein above and below. The next step is to divide the pancreas over that vein. So the vein is right here. You've made a tunnel. Now you're dividing the pancreas. This is the head. This is your tumor. This is the duodenum. And then you're going to have to divide the stomach and the duodenum proximally and further down. And you're going to have to cut across the bile duct because the bile duct runs through the back of the pancreas. So you have to disconnect that somewhere. And we take the gallbladder with that. And then you have to carefully dissect the pancreas off the superior mesenteric and portal vein. And that, if you put a very small hole in that vein, it can lead to a significant blood loss. That just shows the normal pancreas. There's the portal vein, and there's the common hepatic duct. This is what the specimen looks like after you take it out. It's kind of a bloody picture. I'm sorry. I apologize for that. But the pancreas is here. Here's a little plastic stent that was in the pancreas. Here's the gallbladder. The duodenum is down here. And this is what it looks like. You probably just can't see this very well at all. But this tube goes into the pancreatic duct. So when you cut the pancreas in half, there's this duct that runs through it, the one that empties all these enzymes that help with digestion. And that is sitting with this tube in it. And if you can see up here, that's the bile duct. And then you have to reconnect those. And you also have to reconnect the stomach. So that's the complexity of a tumor in the head, is you have to do all that reconstruction. And so you start with the pancreas, and you sew the pancreas to a loop of intestine, usually in 2 layers. And this is kind of the Achilles heel of the operation. Even if you technically do a perfect job of suturing this to the bowel, that pancreatic juice is full of enzymes and has a way of finding its way out and leaking about 1/3 of the time. So we leave a little plastic drainage tube in there to collect that juice. And if it does leak, you just leave the drain in for a long time, and eventually it'll seal off on its own. But it can also lead to infection and some other issues. Then once you've sewn the pancreas to the intestine, then you have to sew the bile duct to the intestine. So this shows the bile duct coming out of the liver, and we're sewing that in 1 layer to the intestine. And then you have to sew the stomach to the intestine further down. Now, there's 2 ways of doing this operation. One is where you take about half the stomach, and there's another where you preserve what's called the pylorus, which is the muscle at the end of the stomach, and this just shows the reconstructions. But they're both the same way. The pancreas and the bile duct both make juice, which will kind of come around the intestine and join up with the food, which comes this way. So digestion can actually be fairly reasonable after a period of adaptation. The problem with this surgery, well, one of the many problems with the surgery, is it just takes a long time for people to really eat well again. It just takes a while to get used to that anatomy. So the complications besides that are death. About 3% of people, even experienced centers, will die within 30 to 90 days of the surgery. And usually it's not immediately during the surgery, but it's some complication, like if you have a bad infection or if you have bleeding, that can lead to death. So it's not an insignificant operation. Delayed gastric emptying is what I was just talking about. About 8 to 45% of people just don't eat well for a while. About 1/3 of patients will have a leak from the pancreas. Again, that'll usually heal by just leaving the drain in. About half the people will require a blood transfusion during this procedure. About 10% of people may have to return to the operating room or get transfused after surgery because of bleeding. Less than 5% will have a bile duct leak. That's unusual. And even less common is leaking from where you sew the stomach to the jejunum. But about 15% of patients will come back to the hospital and need to be readmitted for either failure to thrive or infection or something of that nature. So although the Whipple procedure is a good operation, if you have a tumor in the pancreatic head, it is not without its complications. Distal pancreatectomies have less complications, but still they have a leak rate of about a third of cases, and they can have some of these issues as well. Not quite as many, but it's still not an insignificant operation. And that's why I talked about observing some of these patients, like patients with small tumors. Do you really want to put everybody through this operation? If you're 90 years old, this might be too much for you to handle. In a 1 centimeter neuroendocrine tumor, it might be better to take your chances with that than to undergo a major surgery. Now, you can do some of these operations laparoscopically. It's good for distal lesions in the pancreas. You can also do enucleations laparoscopically, and especially tumors that are in the body and tail, when you do a distal pancreatectomy, they're pretty amenable. Now, there are several individuals in the United States who are pretty good at doing Whipple's laparoscopically, but there aren't that many people who do it well. So if you're going to have a laparoscopic Whipple, you better go to those few people in the U.S. who can really do them. Now, this just shows how we do a laparoscopic distal pancreatectomy. They're basically, when you do it laparoscopically, you put these things called ports in. And these are basically hollow tubes that allow you to put a TV camera in here. And then you can put graspers that help you hold the stomach out of the way, and other instruments to help you dissect. And these are the 5 different port sites that we would use for a laparoscopic distal pancreatectomy. This just shows an intraoperative photograph where we're pulling the stomach out of the way with a grasper, pulling the fat down, and then this is an energy device that we use to divide tissue. It coagulates as you dissect with it. And so this just shows the next step of the operation, which is once you've lifted the stomach out of the way, you're going to free up the inferior border of the pancreas and try to get access underneath it so you can find the splenic vein, and the splenic artery will be right above there. And this just shows what it looks like in the field when you're doing the laparoscopic procedure. Here's the pancreas inferior border has been mobilized. Here's the stomach on top of there. And then the next step is going to be to divide the pancreas, and then again the splenic vein and splenic artery. So we usually do that with staplers, which can do that very efficiently and without much blood loss. And then you take out the specimen and it looks something like this. Now you can see that's the entire spleen. The spleen isn't going to come out through a 1 centimeter incision, so you have to enlarge the incision to get this specimen out. Now, you don't always have to take the spleen also. Now, the spleen has an important immunologic function. It helps protect against certain infections. It also helps to destroy old red blood cells. So in smaller tumors where the splenic vein isn't involved, you can preserve the spleen as long as you preserve the connection to the stomach. There are some blood vessels that connect the spleen to the stomach. The major ones actually come through here, the splenic artery and vein, but there's some minor ones that can then enlarge over time, and you can save the spleen sometimes when you do a distal pancreatectomy. Now, I'm not going to talk about hepatic cytoreduction because Dr. Ioniti is going to talk about this later, but suffice it to say that a lot of our patients present with liver metastases, and in those patients we'll often do a combined procedure where we'll do a pancreatectomy with cytoreduction of the liver, but I'm not going to talk about that because that'll be covered by somebody else. Now, if we look at our patients that we've done resections on, this just shows a paper that we wrote about 4 years ago. Our 5-year survivorship was about 80%. And as I mentioned earlier, from the SEER database, it was like 33%. Our 10-year survivorship was about 53%, with a median survival of 126 months, versus in the SEER, it's about 42 months. If we look at some other groups of patients, this is 112 patients that I've operated on. If we look at by tumor size, greater than 2 centimeters versus less than 2 centimeters, we see that the 5-year survivorship of patients with a less than 2 centimeter tumor is about 96% versus about 75% it was over 2 centimeters. And if we raise the cutoff to 5 centimeters, then the 5-year survivorship was 87% for less than 5 centimeters and 66% for greater than 5 centimeters. And then if we look at patients with metastatic disease here versus patients without metastases, the 5-year survivorship of those without metastases was 93% versus 62% for those patients with metastases. And if we look at those patients with metastases and then divide them up into people that we also did liver cytoreduction, shown here, versus no cytoreduction, then the median survival is 3.4 years in those without cytoreduction and about 10 years for those who did have cytoreduction. So we've talked a lot about medical treatment, but really, we talked about first line, second line. Really, the first line treatment for most tumors, small bowel, pancreas, is surgery. And this just shows with surgery and other multimodality therapies like somatostatin analogs that patients can have long survival. So the optimal approach to patients with neuroendocrine tumors of the pancreas is to take out the primary, if you can, resect the regional lymph nodes in that area. We often will do a cholecystectomy, and there are a couple reasons to do that. If patients are on somatostatin analogs, they might get gallstones, but also some people with their gallbladder will develop pancreatitis from gallstones, and if you've done a pancreatic operation, I like to not have the gallbladder in place so that they don't have gallstone pancreatitis ever. And then, if possible, we like to try to reduce the liver metastases. We put people on somatostatin analogs who have positive nodes or liver metastases, and then we'll continue those until there's progression, and at the time of progression, we'll think about systemic therapy. That's our approach. So I'm going to finish there. I just want to thank everybody else in our clinic, Dr. Odoricio, Dr. Dillon, Dr. Sue Odoricio. They're all here at this conference speaking. Our medical oncologist, Dr. Chandrasekaran, our pathologist, Andrew Belizzi, who is really great at these tumors. We have great nuclear medicine doctors as well, and really good nursing in Kim Miller and Jackie Sexton. And we are also fortunate to have a SPORE grant that allows us to do basic science research and try to come up with new clinical trials and also new advances in the laboratory that we hope will help patients. So thanks again from Iowa. This is our football stadium. This is our undergraduate campus here, and there's a river that kind of divides the undergraduate area from the medical school and the hospital over here. So thank you very much for your attention.